and I think more will become apparent as we move along in the case, so I'm not going to discuss that a lot now.
Yeah, probably worth moving on.
Yes. So if I can go to the next. So a second question. So say in the setting of a mid-CBD stricture, not giving anything away, and no mass, which of the following would be the optimal steps for tissue acquisition? So brush cytology, endobiliary biopsies, cholangiscopically directed biopsies, or all of the above. Also an interesting result.
Cholangiscopy biopsy seems to be the most common.
It is.
So clearly there are quite a few people in the audience who do cholangiscopy. I think probably leave the questions to the end because the case evolves as it goes along.
It does.
Please go.
So just before I play the case, so you can see here that that's the initial cholangiogram that I showed you in that first question, and it looks pretty unremarkable. You've got a balloon that's inflated below the scope and a bile duct that's been filled with contrast, and there's no strictures, no stones, but we're not seeing what's going on behind the scope. So if I now play the video, and I'll show you the manoeuvre, which is to take your locks off, push in with anti-clockwise torque and inject some more contrast. You can see that there is in fact something going on behind the scope, likely a stricture, possibly a stone, but we're going to further assess that with cholangioscopy. And as we do go in with the cholangioscope, we come across a mid-CBD stricture with abnormal friable mucosa, although there's no features that are characteristic of malignancy, tissue is the issue, so we go on and do cholangiscopically directed biopsies. It's also important to note we're able to get the cholangiscope above the stricture and see that there were no stones above the stricture or below, so this is an indeterminate stricture that we need to sample. You can see the biopsies happening there. Because we want to maximise tissue acquisition, we went on to do endobiliary biopsies over a guide wire. Important to ensure here that you're putting them over a wire, using fluoroscopy, and you're below the ampoule when you're inserting these biopsy forceps that can sometimes be difficult to get into the duct. And then finally, as a third method of tissue acquisition, really to maximise this, we're doing brush cytology, pushing the brush up above the stricture, opening the brush and pulling that down as it's opening into the stricture. And here we have the three modalities to sort of maximise our tissue and maximise getting a diagnosis for this patient. So here again, demonstrating that technique, locks off, pushing in with anti-clockwise torque, re-demonstrates that stricture with contrast pulling above it. So we're going to insert a fully covered metal stent, and always making sure we insert temporary stents until we have a tissue diagnosis. And also, I think an important thing to note here is that there's quite a low inserting right posterior duct, so we want to make sure that the proximal end of the stent is landed below the bifurcation. So really discerning your anatomy prior to landing the proximal end of the stent. And there you can see the final fluoroscopic picture with the narrowing of the stent as it goes through the stricture. So in terms of outcomes for our patient, the histology and the brush cytology both came back as reactive changes in fibrosis. Because this was an indeterminate stricture, he went on to have an endoscopic ultrasound, which showed thickening around the upper bile duct, which correlated with the area seen in the DRCP. And biopsies at the time again showed inflammation, fibrosis, but no evidence of malignancy. He then had a follow-up ERCP for stent removal and stricture reassessment, and that stricture had persisted. He had further biopsies taken at the time, which will also show fibrosis and inflammation, and a further fully covered stent being for stricture remodeling. He's had no evidence of progression or features to suggest malignancy over about 9 to 12 months of follow-up now. So I think an interesting case that showcases quite a few points. I think Dr. Webster will talk about some of the learning points.
Yeah, thanks very much, Charlotte. Maybe I could ask a question before that. So you opted for trimodality samples, angioscopy, brushing, structural biopsies. That was not the majority view of our audience. Can you or George comment on what the incremental benefit is from adding each step on top of it? So, most of us would probably, and I think the audience felt that cholangioscopy was the right way to go. What do the other steps add on top of that in terms of percentage points?
Yeah, I think it's a really good point. And the emphasis needs to be on incremental. There are very few good studies directly comparing brush cytology with endobiliary biopsies with cholangioscopic biopsies. Most of them describe that single technique and give you a number. And in the cholangioscopy field, both for visual diagnosis and for tissue acquisition, there are very impressive numbers. But the evidence seems to be that it is combining different modalities that is going to give you the highest yield. And so I think a take-home message is that one modality for tissue acquisition, when it comes to indeterminate strictures, I hate the term indeterminate, I think we should just call them undefined. One modality is not enough. And the promise of cholangioscopically directed biopsies is not actually as great as clinical experience would suggest. Certainly with regards to visual diagnosis, the visual quality of cholangioscopy has got brilliant, and we assumed that just as with colonoscopy, all of us can now see a cancer of the colon and say this is a cancer of the colon. It is not the same with malignant strictures. The features that we believed were defining an almost pathognomonic of malignancy of altered blood vessels, friable mucosa, maybe ulceration. I'm sorry, they don't hold true in clinical practice. And similarly with tissue acquisition, as Charlotte used the now corny but much used but very relevant phrase of tissue is the issue, that remains important. And it is going to be the additive impact. And there's some studies, for example, by Christian Gerges recently, showing the additive role of cytology with another modality. And I think a point that actually Max made in the last case, I think the days in which doing brush cytology on its own is an acceptable push to make a tissue diagnosis. I think we really need to move beyond that, to be honest.
Yeah, thanks, George. Maybe I could just ask you to take us through your final slide, and then we'll finish with one or two questions.
Yeah, so a few little points. I think it's absolutely vital that, well, actually, almost every patient having a biliary intervention or an ERCP, cross-section imaging has to be reviewed beforehand, particularly if it comes to tissue stricture assessment.